welcome. Tonight we're going to learn, at least I'm going to learn, all the wrong things I do when it comes to sleeping. I can already tell. But we have a couple of special people here tonight, so we'll start with an introduction, and then we're going to ask Ms. Nicole to tell us a little bit about Tri-County. So let's start with an introduction.
Good evening, Al. Thank you for having us here and for representing Tri-County Medical. My name is Nicole, and I'm the marketing coordinator at Tri-County Medical. So I'm responsible for about roughly 100 doctors within the Milford regional system and their marketing and how to get their name out there. So to explain a little bit about what Tri-County does is we are a physician outsource group for the Milford Regional Medical Center, and we take care of about 100 doctors. That includes primary care physicians, including pediatricians and an adolescent physician. We also have specialists that include 2 of our new rheumatologists, including another rheumatologist out in Franklin. We have an infectious disease specialist. We have a lung, allergy, and sleep physicians, which Dr. Richard is part of. We have a sleep center, and we have several other specialties, including adolescent behavioral health. We have Dr. John Levine, who's been on the show before. And I think that's about it. And we're we have an OBGYN, Dr. Catino, and we have a urogynecologist out in Whitensville, Dr. Zylstra. So most of the doctors in the Blackstone Metro West area are Tri-County.
So now why is it that, Uncle Phil's been on and he gave us his view. Why is it better to have the physicians as a separate group from the hospital?
They're not necessarily a separate group. They're just where they practice is separate, but they have admitting rights into the hospital. So when you see your regular physician outside of a hospital setting, you are seeing a physician in our group.
So you're able to take like some of the specialties like child psychiatry.
Right.
And bring in specialists like Dr. Levine.
Yes.
And tonight we'll learn about sleep disorder and sleep, maintenance and good practices, where normally you wouldn't have that kind of diversity.
Right. So we're mostly, actually the only specialists we don't have are the cardiology group. They're the Hopedale Cardiology. We have Milford GI is another one, and basically we're all the other medical specialties around this area.
Well, it's been an exciting time to learn about all the services that we get at the center of the universe.
Yeah.
So I guess we might as well start talking about sleeping.
Yes. Thank you again.
Okay, so now we're going to talk about the topic of the day, which is mainly sleep. Let's start with an introduction.
My name is Kathleen Aris-Richard, and I did my training at UMass, and that was in internal medicine for 3 years in residency, and then a pulmonary critical care fellowship for 3 years. And I've been working for Tri-County Medical Center, Tri-County Medical Associates, and also at Milford Regional Medical Center since 2004. I'm the director of the Tri-County Sleep Lab, and I'm board certified in pulmonary critical care and sleep.
So how do you move from pulmonary critical care to sleep?
Sleep is interesting because it can be a specialty by general medical doctors, general pediatric doctors, psychiatrists, neurology, and for the pulmonary, it leads right into obstructive sleep apnea. There's sort of an overlap there. Many of the patients, especially with obesity or COPD, their oxygen levels are affected at night, and so that was a natural lead into sleep.
Now, when we think about general sleep, it seems like we're reading a lot that people ought to get more sleep than they normally do. Tell me when you say this would be a good guideline, what would you recommend?
A good guideline for adults and how much sleep we should get is 6 to 8 hours. Our bodies follow a circadian rhythm.
6 to 8 hours a night?
Yes.
Wow.
Our bodies follow a circadian rhythm, and it's best if you go to bed at the same time each night and get up in the same time each morning. Most people work a Monday through Friday schedule and then the weekends, and it's difficult to do that. The most common cause of sleepiness during the day is insufficient sleep syndrome, and probably 30% of the population is suffering from that. When I say suffering, it's people who are working too much because our jobs demand that there are very few people, I think, at this point who are working full-time and only do 40 hours a week. And then people let loose on the weekends. They tend to go to bed later and get up a little bit later. And it makes Sunday night very difficult to get back into that routine. You probably slept later on Sunday morning and went to bed. It's hard to go back to sleep at the usual time. So our routines make that difficult. Our bodies actually have a circadian rhythm, and even though the clock is on a 24-hour schedule, our bodies are actually about 24 hours and 15 minutes. So that tendency to go to bed a little bit later each night, it's actually real. And so you can make it a certain amount during the week, going to bed a little later, if you can catch up on your sleep during the weekend.
But now you say 6 to 8 hours.
Mm-hmm.
Seems amazing. I mean, I know as I've gotten older, I need 5 hours a night or I'm in trouble. Mm-hmm. When I was in college and all, you could go 3 hours a night, and it was fine. You just keep going. But now, you know, that 5 o'clock or 6 o'clock, whatever people, it seems like no matter what I get used to, I'll wake up about 5 minutes ahead of that alarm. How does that happen?
Our body's need for sleep and our sleep patterns do change over our life cycle. So you kind of can picture a newborn where they sleep and then they're awake, they sleep and they're awake throughout the whole day. And then toddlers need more like 11 to 13 hours of sleep. And then they grow out of that a little bit. And then adolescents tend more towards 8.5 to 9.5 hours of sleep. And adolescents actually usually tend to go to bed later and get up later. That's normal for that age group. It's ideal if they can grow out of that and adjust to a normal day.
Well, I've seen studies where they've said if we were really setting up our school system for the children, mm-hmm. we would start school at 11 o'clock in the morning or something. For the teenagers, right. Right.
But then I think, you know, as a mother, you'd see the little ones out there during the dark. It's dark now at 6:30, 7 o'clock. So things that are ideal, you can't always do logistically.
But the school hours are set because we have to go to work.
Right, right.
I can't just sit home. I mean, this whole work thing is overrated in most cases, but for people who have to work, I can't just sit there and play with my kids, although it would be a lot of fun, till 8, 9 in the morning.
Right.
And then take them to school. I have to be to work.
Right, and sometimes it's the same bus driver picking up the kindergartners as the older kids. So yeah, you have to do things according to life. But that is the ideal, that teenagers sleep in. And sometimes people don't need to grow out of that way of sleeping. They can find a job where they work from home or they go in later hours and stay later, and that decongests the roads maybe.
That would be nice.
Yes, it would be nice.
I mean, I laugh because my daughter's doing an internship. Now, if you gave her the option, I think she'd sleep till 11 or noon every day. Mm-hmm. But yet this morning at 6 o'clock, she was already out the door because she has to drive into Boston. So she's learned the hard lesson that if you're living here in the center of the universe, if you're not out of the house and on the road by 6, mm-hmm. it could take you an hour and a half to get into Boston.
That's true. And I mentioned that circadian schedule, our tendency to go to bed a little bit later. Well, there are certain things that keep us to that schedule. And one is social. So whether it's meeting a friend for running before driving to work, that gets you up at that time, or beating the commuting traffic. It's also light, and it's what we eat and drink each day, too.
As here I am saying alkaloids are my friend. So I have a trough of caffeine. Mm-hmm. You know, and it's funny because I know friends of mine, if they drink coffee, any kind of stimulant, you know, but caffeine being a pretty good one, late at night, they have a hard time going to sleep. Mm-hmm. I must have developed an immunity because I'll drink my coffee before I go to bed.
There is a certain amount of tolerance that we get to caffeine. There is also a matter of being overtired. Maybe you're tired enough, too, to just fall right to sleep. So generally, you want to keep the caffeine early in the day because it actually has about a 6-hour half-life. So if you drank that much at 6 o'clock, at midnight, you'd probably still have about half of that in your system.
Oh.
And that can make awakenings during the night a little bit longer.
Now, when you say awakenings, you wake up in the middle of the night?
Mm-hmm.
Why?
Different things can wake you up in the middle of the night.
Dog barking is one, that I
Yep,
know.
Yep. Spouse snoring, spouse rolling over.
Well, if I comment on that, my darling bride will hurt me. So I'm going to leave that one alone.
Yep. The heat going on. Perhaps you're trying to figure out why your child wakes up at the same time each night. It may be something going on with a neighbor or your refrigerator turning on, a dog barking. So it's interesting to get perspective from other people's houses, whoever in your house, you're trying to figure out why they're wakening. So the caffeine, ambient noise. Also, you got to admit those commercials are louder than the other
Yes.
parts of the TV. So leaving the TV on can also wake us up later in the night.
So somebody who falls asleep with the TV on, I'll get home tonight after hockey. So I'm going to roll in about 12:30. TV's wide open, darling bride dead asleep. But I hadn't thought about that because when they elevate the volume,
It does, and it's blinking. You know, I can tell the TV's on when I arrive to my house too, because you can see the light changes on it. You know, to a certain extent, that's affecting your sleep, even though you look like you're asleep.
so you're saying normally, you know, if you take a typical toddler, 12, 13 hours is normal. For a teenager, 8 to 9,
And when I say a toddler, that's through a 24-hour period. So if your child's starting to grow out of naps as a toddler, they may be getting that sleep all consolidated and going to a more adult schedule where they're awake completely during the day and then they get that at night.
but does it, now here's a question that I never quite understood. If I do 4 hours now and 4 hours later, does that equal 8 hours of sleep?
Not in a 24-hour period, no, because your sleep has to go through certain stages. So you're always going to start with light sleep, and then you get into deeper sleep, and then it actually cycles from stage 2 to REM, and stage 2 is a lighter sleep, and it's your early deep sleep and then your later REM cycles that are the most refreshing. They probably help with immune function and memory consolidation and that restful period.
But now, okay, if I take 8 hours, so let's just say midnight I go to bed. My initial stage 1 sleep, when does that end? 1 o'clock in the morning, 2 o'clock?
Oh no, long before then. So for an 8-hour time period, only about 6 to 8% is stage 1, and that should be just the first going to sleep, maybe a brief awakening, but it's not long at all. What is that, 20?
20, 30 minutes,
Yeah.
then I roll
Yeah.
into deeper sleep
Yep,
for how long?
typically stage 2. Stage 2 is going to be 50% of that 8-hour sleep,
So I'll
but,
go 4 hours.
but not right then. Maybe an hour right then. And then it's stage 3 sleep. Stage 3 sleep is about 25% of the entire sleep period in your adolescent years. So teens, 20s, we start to grow out of that as we get older too. So as we get older, we get less of the delta sleep, which is deep sleep, stage 3 sleep, and we get less of stage REM sleep. And when I
So-
say older, I mean like in your,
About 12:30, I'm falling into my stage 2, if I went to bed at midnight.
yep, yes, you should be in about
So I
stage
go a
2.
couple hours of stage 2, then I go into my stage 3.
Yeah, even less stage 2 than that.
So an hour,
Probably,
1:30.
Yeah.
And how long do I stay in my stage 3? Is that the REM?
Stage 3, yeah, you might have 40 minutes or so of stage 3. Nope, that's not REM. Then you'll go back into stage 2, and then you'll go into REM.
Why?
Because that's the cycle.
But I'm happy at stage 3. I'm nice and sleepy. I'm getting refreshed. Why does my body now start cycling?
Yeah, that's a certain neuroanatomical and neuroreceptor pathway that leads us into stage REM. There are disruptions in that. So say, for example, somebody with narcolepsy, they may have onsets and offsets of stage REM that they can't control in any way through a whole 24-hour period. So stage REM is actually marked by low muscle tone, and so it is deep sleep, it's dream sleep, it's refreshing sleep, it's low muscle tone, and your eyes typically move. That's why they call it rapid eye movement sleep. it's most of our sleep towards the early morning hours. So if you went to bed at midnight, 6, 7, 8 a.m., you'd be cycling in REM and stage 2, about 20 or 30 minutes each, cycling like that. But somebody with narcolepsy who has a disorder of stage REM, they may be looking asleep in stage REM but have high muscle tone, or they may have low muscle tone while they're awake, which is actually called cataplexy. So their muscles just drop. They may fall on the floor. The studies with...
They're still wide awake. They just fall.
Yes. And there can be less dramatic things than falling, where maybe they laugh funny or they garble their speech. It almost looks like a stroke.
A stroke?
Yeah, yeah. And these people would be mostly teens, sometimes in their 40s, so I don't want to...
Is it a chemical imbalance, or?
It is, probably serotonin.
We like serotonin.
Yeah, we like
Serotonin's
serotonin.
good. But now, what biomarkers, I have a sleep disorder, and I sit there and say, what are the typical sleep disorders that I'm going to run into?
So the most important thing is to take a sleep history, because sometimes we're doing it to ourselves, overworking or being on call or
Drinking
keeping
a
our phone.
trough of caffeine, yes.
Alcohol also right before bed can delay stage REM. So a night after drinking alcohol, there won't be much stage REM. That's why people feel sluggish sometimes the next day. So it is a lot of what we do to ourselves.
So literally, ethanol will have an effect on your sleep cycle? I always thought you see people drinking, they pass out.
Right, it's not good.
It's not a
refreshing
good sleep.
No. So the sleep history is the first place to start if there's a sleep problem, and for why people are tired. Because that's what usually they come with.
Okay, but now, Kate, when you say sleep history, that means something to you.
Yes.
To the uneducated, what does sleep history mean?
I want to know what you do before you go to bed. Do you watch the TV? Did you just do your checkbook? Are you falling asleep at your computer doing work? I want to know exactly what's happening then. Because, like I said, you want to keep it regular. So you want to go to bed at the same time. And this is ideal situation. I know people don't really go to bed at the same time, Tuesday night and Saturday night, if they work a Monday through Friday schedule. But I do want to know that. Or is it somebody who works 8 to 5, 2 days in a row, and then 3 to 11, and then the next day they have to get up early in the morning? So what's your pattern of work, of what you eat? When do you exercise? Do you exercise right before bed? That can be stimulating also. You need an unwind period before bed. So I want to know what people are doing then, the amount of caffeine and alcohol they take. Do they nap during the day? Are their naps refreshing? Do they stay in bed all day? So their body doesn't know when they're in bed, are they supposed to be awake or are they doing their work?
Well, I know that I get home from a game, it's 12:30, 1:45. My eyes are open. It takes me half an hour just to kind of, I call it just chilling out, to where I can close the lights, roll over, and count those miserable sheep for a long time before I fall asleep, or I can just watch TV for 20 to 30 minutes and then I go to sleep. So that's the stimulation, like exercise?
Right, right.
So it's not good to be exercising immediately before you go to bed.
Exactly. And that can happen to me just folding the laundry and jumping in bed. You need an unwind period. So the routine of, brushing your teeth or whatever you do to kind of relax, even reading a few pages of something, whatever it is that relaxes you. And it can be TV, but again, the TV with the noise and the...
yeah, but something that puts your mind more into neutral.
Right.
Because I can't imagine that adrenaline's your friend at night.
And people do a great job marketing things. It can be a certain odor, lavender or orange, but just that routine, I think.
That was something I always got a kick out of, because you heard, if you put on this fancy schmancy clock and it has ocean sounds or wind sounds, it'll help you go to sleep. And I always wondered, is it a placebo effect, that it just a routine, you're now putting your mind into neutral, and regardless of what sounds, or I don't understand how a smell would make me go to sleep, but...
Exactly. Part of it is the routine. I think mainly it's the routine. But you do want to kind of empty your mind. If your mind's still running, even if your body's at rest in bed, then you're probably going to have trouble falling asleep.
That's what I find at night. You put on some of these mindless shows that, you know, you've DVR'd, The Big Bang Theory, and I laugh. There is no neural activity going on watching this. You've shifted your mind into neutral, and it gives you that 20-some minutes just to calm.
Exactly. And so about 1 in 10 people will have trouble with insomnia, and the difference is somebody who knows that they're going to fall asleep if they just try to relax and they do their usual routine. The problem is when it's somebody who's had a real problem. So maybe work is really stressful, or maybe you've changed and have a medical disorder or something going on where now you can't fall asleep, but you're forcing yourself to lay in bed. Now your brain is going to start to realize that, oh, bed is where I struggle to fall asleep. I lie awake. So one of the worst things you can do is lie awake and try to fall asleep, because you shouldn't have to try to fall asleep. It should be kind of passive. There are people who take longer to fall asleep than 20 or 15 minutes, but we generally say if you can't fall asleep in 15 to 20 minutes, you should get out of bed and do something relaxing. And you may even fall asleep there if you're relaxed enough, but you need to keep it dark, so not to watch the TV
Eliminate
closely.
external stimuli.
Right, right.
I mean, I think about it, when I'm wound, I pick something that I remember that was the most relaxing, which was going out with my darling bride on our sailboat on the Chesapeake. And I used to just fall into a mind-numbing state of just watching the little ribbons on the sails, listening to the waves hit. And if I'm ever wound up, all I got to do is think of that. And it does seem to just, you can feel the adrenaline. Somebody did the Achilles thing. They pulled the plug out of my heel and all the adrenaline drains away. And it just calms you down.
Right, right.
Now, when we look at, I can't fall asleep. I wake up in the middle of the night multiple times. Okay, and that can be physiological. As you get older, you could have a body function that needs attending to in the middle of the night, that your body's going to wake you up. What other disorders do people typically come to you with?
So I mentioned the insomnia, the narcolepsy. There's two things that disrupt your sleep that you may not know about, and that's when you need to have a sleep study. The two things that disrupt your sleep are periodic limb movements and obstructive sleep apnea. Besides obstructive sleep apnea, you can also have central sleep apnea. But those are disorders that would need a sleep study. So the person who...
So if I've got restless leg syndrome, that's going to wake me up.
It may. So the person who has restless leg syndrome, when I'm getting that, when I'm asking them about their routine at night, I say, before you go to sleep, is anything bothering you? Do you have a discomfort in your legs? There are people who say, you know, I have knee pain, I take a Tylenol, I get rid of it, it just goes to sleep. But the person with restless leg syndrome will say, yeah, every time I sit down and relax at night or I'm trying to go to bed, I have this funny feeling in their legs. And they describe it in different ways. But it's a discomfort in the legs, it comes at rest, it's worse in the evening, and it's better when you move them around. But how can you fall asleep if you're moving your legs around?
If you're sitting there moving my leg.
So that's restless leg syndrome. And then there's a certain amount of people who will have restless leg syndrome who will move their legs throughout the night. And that's something that needs to be done in the lab. So the sleep laboratory, it's a person comes into their room, it's a bedroom with a private bathroom at Tri-County Sleep Center. There's a little TV. I usually say it's not one you want to watch the big game on, but it's comfortable enough if that's your routine. They bring their own medications, but then a sleep therapist sets them up. The setup is EEG monitoring to see what stage of sleep they're in, and then airflow monitoring in front of their nose and their mouth, and leg movement monitoring, oxygen monitoring, EKG monitoring so we can see their heart rate, effort to breathe monitoring. There's bands around their chest and abdomen.
I got 4,000 wires on me and I'm going to go to sleep?
So the typical person who ends up in the sleep lab is somebody who says, I get 6 to 8 hours of sleep. I get 10 hours of sleep, and the more sleep I get, the worse I feel. Or I get 10 hours and I feel like I never went to bed. I take 2-hour naps and I can't get up from them. So it's somebody who's getting enough sleep but feels tired.
So they're getting the wrong kind of sleep.
Right, so it could be a problem with what stage of sleep they're in, or there could be something disrupting their sleep that they don't awaken enough from sleep to know what it is, or it's not long enough for them to realize they're awakening. And actually, there's a lot of people who say, I get up, to use the restroom 2 or 3, 4 times per night, and they say it's from their prostate, from their diabetes, they drank too much before bed, and then afterwards they may say, you're right, it went away with treatment for obstructive sleep apnea. Those are the best, because I used to tell people that, and now they come back telling me, I don't get up to go to the bathroom as much anymore.
So if I stop drinking before I go to the bathroom, what a surprise. I mean,
Right.
before I go to bed.
Right.
Yes, I don't go out and drink half hour before I'm going to sleep, and I don't have to get up to go to the bathroom very often. Okay, that doesn't sound counterintuitive.
So it's actually, people may actually be using the restroom because something woke them up, and they don't know what woke them up. It wasn't the dog, it wasn't their spouse. They swear everything's quiet, they live out in the country, it's not a train going by or something. And so that's what the lab does, is we find out if there's airflow limitation, where there's less airflow, because we see these as waveforms, during the night while they're sleeping, but also I can review it after they've had their sleep study, and there are people called scorers who go through and count every time the airflow decreases and the oxygen changes, or the patient's brainwave activity changes for 3 seconds.
Well, you mentioned environmental. It would seem like the easiest thing, unless you have some identifiable issue. Like, my spouse snores like a train wreck. Okay, so if I go to another room, it's now quiet, right? And I'm not listening to somebody make loud noises. That seems easy. But it's funny, because I bet people don't really think that cycling of air conditioning, cycling of other equipment can have an effect. And maybe something as simple as get out of your bedroom, go sleep at the other end of the house in the guest room.
Right.
See if it makes a difference. If it does, okay, then you can look and say, do I have a miserable bed? Or, is the neighbor's lawnmower, not lawnmower at that hour of the night, but maybe the neighbor's air condenser for their air conditioning kicks on. It could wake you up.
Right.
Now, when I go into the sleep center, I'm going to go in and you're going to wire me up. Do you look at chemical biomarkers? Like, I'm reading about melatonin levels. Do you monitor melatonin levels, or?
No, we don't look at those kinds of levels for the things we talked about at the sleep lab. The other thing that we can't test for at our sleep lab is if reflux is waking you up during the night, or if pain's waking you up during the night. We rely on patients to tell us that. You can do blood tests for narcolepsy. They can sample cerebrospinal fluid for narcolepsy. We do blood tests to see if somebody has a thyroid problem, because you can be tired from thyroid disease.
What are you looking for in CSF?
It's
Is it a specific biomarker that they can analyze for? Or?
yes.
Wow. 'Cause I always wondered chemically, if I'm in your sleep center, and I see the debate going on as to, do I want to do serum melatonin levels or saliva melatonin levels? I'm fascinated as to, how do you take a sample and not wake me up unless you've stuck an IV tube in my arm?
Right. So they do studies on people with arterial monitoring and esophageal monitoring.
Yes.
It's hard enough to get people into the lab.
Wait a minute.
We don't do blood
We
monitoring.
want you to
during
come
that.
in and go to sleep, and I'm going to stick a tube down your throat.
Yeah.
Boy, that's going to make me calm and want to go to sleep.
Right. And again, the people who end up in the lab are usually people who are tired. So generally, we don't want people with insomnia in the lab. There are people who say, I wake up multiple times during the night and I really don't know why. So sometimes those people end up in the lab. But we want the people who are, like sometimes I need to even, the spouse is there and saying, you've got to do something. The spouse, so 2 spouses in the outpatient office with me, and the one spouse is the patient, and the other spouse is saying they snore, they're falling asleep at supper time, they're falling asleep driving. Those are the patients who really have a sleep disorder that we need to figure out.
But now, if you really want to test my sleep patterns, and you put me in this little bed, totally, I mean, I've been sleeping with my darling bride for 100 years. Right, wrong, or indifferent, she's part of the environment that I'm used to. You know, if you have somebody with, a woman or man, with a spouse that makes lots of noises, wouldn't you want them in the bed with them to see if they affect it, or?
No, because I'm not going to do something to the spouse making the noise. That's something that people have to take care of at their own house.
Yeah, flying elbow always works for my darling
Yep.
bride.
Yep.
Yes. If I'm snoring, I can count on a rib being bruised. So she lets me know very quickly.
You'd be surprised at how many people end up in separate beds by their 60s and
Is that right?
yeah,
I would get my covers back.
covers back because the hot people marry the cold people, the white noise people marry the completely silent people.
Well, I learned when we got married that we each got half the bed. I got the quarter on either side, and she got the half in the middle.
There you go.
So I learned very quickly, defensively, to put the sheet between my legs, put a death grip on it. Otherwise, she would do this cocooning action, and I would wake up middle of the night. That was my stimuli of being cold. As she was wrapped up. You know, so and it's funny because you start thinking about all the little things that could affect your sleep. So once you do your studies, what are some of the common recommendations?
So we look at the sleep study to find out how much sleep the person got, how many times they woke up, how much time was spent awake in the bed, what stages of sleep they had, those stage 1, 2, 3, and then REM. We look to see their oxygens, their heart rates, and how many arousals they had. So if it's in the lab, we can see how many times their brain changed activity for a 3-second time period, which is very subtle. So that would be higher than people at home would notice that they were sleeping or waking up.
3 seconds, I'd be hard pressed to see that kind of resolution. Just, you're half groggy from sleep anyway.
Right, and it may only be from, say, stage 3 to stage 2.
So that cycling period.
But it's so brief that it's counted just as an arousal. So then we look, well, what woke that person up? Was it kind of a snore awake, or was it a limb movement? And then we count up those things. So we can tell if there were decreases in oxygens throughout the night. Obstructive sleep apnea is usually caused by an anatomical problem. So it's just you. Somebody has a certain anatomy that makes people prone to obstructive sleep apnea. It can be worse with nasal congestion or a broken nose, face trauma, and then it gets also worse with weight gain and
Yes, you're looking at me, just like my physician. Yes, weight gain. He keeps telling me that, you know, in his words, you fat old man, you must lose weight.
I was thinking age as we get older, because you can't fight getting older. So even if you have mild obstructive sleep apnea, in 10 years it may be a little bit worse.
But now, physically, I mean, I see on TV, you can buy these biting things, and supposedly, if you snore, it moves your palate, it slices, it dices, it does all these good. Do those things work?
Well, there are 3 main ways of treating obstructive sleep apnea, and one is oral appliances. So the oral appliances need to pull your lower jaw forward.
Right.
And generally we like those made by a sleep dentist, and we like to prove that it made it better in the laboratory. But there are a certain degree of those that will help some people who have less severe obstructive sleep apnea.
And they can go to sleep when you got your mouth full of plastic?
So just like braces, they move it a certain amount, and then as you adjust to that discomfort, you can move it forward, and you don't need to move it forward anymore. This is, again, made by a sleep dentist.
Is it a treatment then, or is it, you know, when I think of a therapeutic, I think of a treatment that lasts forever versus a vaccine, where for a short period of time, in many cases, it's a shot, in many cases, it's a series of. Are these physical oral treatments something that, like braces, move the body and then you can stop using it?
No, you would use it every night.
For the rest of your life, you're chomping on plastic.
Yeah, unless you lost enough weight to get rid of your obstructive sleep apnea.
Here we go again.
I know.
So fat old men, yes. The cure to everything I keep hearing is you must lose weight. And I'm like, yeah, my mind keeps saying that, but my fat old body says I'm happy at where I am. But it can be a weight issue.
It can be a weight issue. And then, but yeah, once you're diagnosed with obstructive sleep apnea, it would be surprising to get rid of it unless something dramatic changed.
So if you go through a substantial loss of weight, that could help you. Is it because the oxygen demand is less, or is it a physical issue?
It's a physical issue. You know, I look at those football players when they show those mug shots. You're at risk
The
of
no
obstructive
necks.
sleep. Yeah. So the neck circumference makes you at higher risk for obstructive sleep apnea. Again, age, and then weight gain, and then people with high blood pressure or atrial fibrillation are also at risk of having obstructive sleep apnea.
Okay.
And underactive thyroid is also a risk factor. So if you have underactive thyroid and you're diagnosed with obstructive sleep apnea, you treat both at the same time, that would be another hope that maybe it'll go away when you treat the thyroid disease. But I haven't seen many people just suddenly get rid of their obstructive sleep apnea, right?
Now, when you say obstructive sleep apnea, that makes me think, is there an unobstructive sleep apnea?
There is. So obstructive sleep apnea is this. It basically closes off when you're asleep.
Physically, my neck's I got too much fat, it's too wide, my jaw's back too far.
Right, so the inside is all little muscles holding your neck open. And so when you're asleep, those are relaxed. When you have a sedative, that's even more relaxing. So, you know, people going in for their colonoscopies or drinking alcohol at night or even Benadryl.
Relaxing? Colonoscopy?
Relaxing, the sedatives they give you.
Oh, the sedative. I was going to say, wait a minute. There's something not right about that sentence.
Yeah, no.
There's nothing relaxing about having a VCR stuck in your body.
They typically give a medication like Valium and a narcotic, and those all make this worse.
Oh, okay.
So people coming in, a colonoscopy was an example of people coming in for procedures. So we often find out people have obstructive sleep apnea when they come in for surgical procedures too, because they get narcotics for pain, and that can make it worse. So obstructive sleep apnea, it can also be worse on your back or in stage REM because you have that low muscle tone in stage REM. So that's obstructive sleep apnea. There are other types of sleep apnea, like central sleep apnea. So central sleep apnea, your brain doesn't send the message to breathe. And that
You hear about people who stop breathing at night. Mm-hmm. I mean, that always amazed me. How can you just stop breathing?
Right, so either it's an obstruction where the air isn't getting through, or your brain doesn't send the message to breathe. And that can be seen actually with central congestive heart failure. Some of the neurological disorders also, narcotics can make you stop breathing also because they're respiratory suppressants.
But isn't it, if I'm doing narcotics, now I'm messing with my synapses. Mm-hmm. I mean, I can understand that. That's an easy one. You're doing bad drugs, stop.
Yeah, but some people are taking those narcotics for pain. They don't, you know, they're not doing it intentionally to stop breathing.
So this is not what's referred to as recreational or...
Right, not necessarily, right.
This are people who have legitimate prescriptions, and one of the side effects, again, our friend serotonin, you know, I mean, you start looking at all the dopamine, all the catecholamines that we love so much. Mm-hmm. The receptor sites start getting messed up.
Right, right.
And that can affect my ability to sleep.
And so that's why at the sleep lab we need that airflow monitoring, and we're looking for the breathing. And yeah, sometimes the breathing just stops. There's no airflow and there's no effort to breathe by the chest and abdomen.
So when are you measuring like tidal volume, the total flow of air in and out, or?
We can, but nope, it just looks like a flat line, or it looks like a decreased line on the waveforms. For all those wires that people are set up with at the sleep center, we have a line on our computer screen And we're counting.
But when you're measuring the volume of air, or what are you actually measuring when you say the air? Is it the amount of air coming out? I mean, the oxygen levels I can understand. Or can I? Where would I be measuring that? In the lungs?
No, it's an oxygen probe.
Just an
put
oxygen
on the
probe on
finger.
the one you
Right.
put on your finger?
Yep. It's by like a light spectrum analysis.
Okay.
So we're looking at night for that obstructive sleep apnea or central sleep apnea, and the limb movements. So sometimes there's no breathing abnormalities at all, but there's limb movements.
So just automatically my leg starts to move, or?
Right, so the leg is moving and the brain is wakening up, and that's why the sleep is disrupted.
What can you do for somebody? I mean, if my brain is telling my leg or my arm to move, you know, apart from the normal, I've been leaning on that side and the body just says roll over because you're falling asleep. What can you do for somebody who has limb movement?
Well, those people, we make sure that the ferritin is high. The ferritin needs to be over 50 to, they've basically shown that the ferritin under 50 can be associated with those limb movements. So the first thing we give them is iron and vitamin C, and then we try to recheck that ferritin. Sedatives can also decrease those limb movements.
So when you look at sleeping pills, you know, the magic of take a pill, you know, better living through chemistry, what is that really doing for you when I take a sleeping pill?
I would argue that it's getting you through the time period that it takes to relearn how to protect your sleep and keep a cool, dark sleeping environment, cool, dark, quiet, and maybe it's getting people through a time period when they're having trouble with insomnia. But hypnotics, sedative medications
But that's a
are not.
short-term, you know, that's like putting a cast on your leg for a broken leg.
Right.
Makes sense that, you know, when I snapped my leg off playing hockey, they stuck titanium rod and screws and all sorts of stuff in there. 2 years later, they said, okay, now we got to go in there and take it out. That was the bridge to get my leg to heal. But leaving it in there would cause all sorts of atrophy because it would be the weight bearing. So what you're saying then, if I understand it right, is short term, there may be a place for chemical assistance.
Right.
But if that's your long-term solution, that's just going to exacerbate the problem.
Right. You do become dependent on things. Like you said, the receptors upregulate. And those sedatives are not perfect. If they were onset at midnight and offset at 8 a.m., great. But there's always a little lead-in to get it into your system and a little hangover the next day of the drug still being in your system. You have to be very careful about driving if you're taking any sedatives. You have to be very careful about driving whether you're sleepy from any cause. And then they do have behavioral modification, though, for insomnia.
And when you say behavioral modification?
People learn how to go back to sleep, learn how to, like I said, do the sleep hygiene and protect their sleep environment. And I usually refer people out for behavioral modification. It's about 6 weeks of therapy.
But now, when we start talking about sleep center and 6 weeks of therapy, does insurance cover this?
Insurance will cover a certain amount of the sleep center cost. My general sense of what the insurers are covering these days is they're making people pay for more out of pocket for your insurance and more out of pocket for co-pays and the deductibles, and those are a constantly changing target. So the sleep center can do studies inside the sleep center and outside the sleep center. We have limited monitoring ability where people take the equipment home and they go home and sleep with it. We can't diagnose the limb movements by that, though, and that's not recommended for people with sleeping problems at night from neuromuscular disorders. Because
So you can't just stick a camera over your bed, feed it into a laptop, and say record for the next 6 hours.
Right. Not to diagnose some things. That's a whole different night.
I was going to say, you know, realistically, the cost must keep some people from going in.
Oh yeah, I'm seeing that absolutely now.
And yet, everything I read says that lack of sleep can have all sorts of physiological effects.
Yes, they've taken normal college students and sleep deprived them, and their blood sugars are all over the place, too high. So essentially putting them into a diabetic
You're
state.
forcing diabetes.
It can also affect the regulation of thyroid hormones, cortisol levels, and the immune function is worse without sleep.
How does it affect your immunological response? Do you have any idea?
Again, part of it is the circadian rhythm of the hormones, and being asleep and going into certain sleep stages affects the hormones and when they're released.
Okay. So now, most of us work or are employed. I don't know if everybody works. A lot of them are employed 9 to 5, and you never do 9 to 5. But you see people who work the graveyard shift. I mean, God bless the nurses who are on 11 to 7, because somebody has to be there. You know, the emergency workers, the firefighters, the police. Aren't they almost fighting an uphill battle just from their work schedule?
Yes, there are people who have, and there's a name for it, of course, so shift worker sleep disorder.
Shift worker sleep disorder. Okay.
Right. And so that's one of those circadian rhythm disorders. Ideally, they get 6 to 8 hours after they get home, but then you've got, the mail person coming to the door, dog barking, the phones are ringing, so they need to take extra special precautions to try to protect their sleep.
Now, if I went into a person cave, I'll be correct, I won't call it a man cave, but if I work 11 to 7, I get home, and I was able to put myself into a sealed chamber, no external stimuli, would my body automatically readjust my circadian rhythm and there would be no downside, or is there something just not natural?
Yeah, you still would be best off with the light triggers to get those. It would still be best for the light to keep that circadian rhythm going at the right part.
I would imagine it's so difficult, because even if I can regulate myself Monday through Friday, that's why you feel terrible for the people who work in restaurants and service business. Because when we want to be out with our friends enjoying ourselves, they have to work.
Exactly, New Year's Eve. And
So you turn around and you say, even if you could put yourself away in a cake cave Monday through Friday, come Saturday, Sunday, you're going to want to go out with the family, with everybody.
right, that's those social triggers and the light putting you on that schedule.
So there your body's going to get totally confused again. Because I can't do my rhythm 5 days on, 2 days off like I do my schedule.
Right, and it is a sad existence to try to stay on that schedule and miss your family's usual activities. So again, most people
Thank
I
God
think
that
don't
some
do
people do it, because you can't send the memo that you will not be sick between the hours of 11 and 7.
Right.
That way we don't need nurses or anybody. If everybody could get the memo, then that'd be okay.
Yeah.
So people have to live through it, but what do?
They do different things. I think they make up their sleep sometimes when they're back on the night schedule. They might sleep a little bit longer then, but that's different for everybody.
Yeah, and then you start thinking about it, the poor people who are on, and like, you see our firefighters where they're on for 24 hours, and you sit there and say, you can't really plan your sleep.
Right, so I think the people who are on for 24 hours, even somebody carrying a beeper at home, you're kind of half awake. When you wake up, oh, did I get beep? Did I miss a beep? Why did I wake up now? Is there a beep? I think that happens with the general population too, half listening for a baby, half listening for a teenager to come home.
Half listening for this dang cell phone. Somehow, I remember that there used to be an old TV show called Babylon 5 where they had the communicator kind of glued to their hand. And I wonder how close we are, because my daughter seems to have her iPhone glued to her.
Right.
I go in at night, it's right next to her.
I feel like I have to tell the teenagers, there are ways to get in touch with you in the case of an emergency. Even if you think it's just that phone, security can come to your dorm room. Just put
Yeah, but
them
even when
off
she's
and
home,
shut them
I
off.
think it
leave
just
the-
becomes Pavlovian, that she has that dang phone.
Mm-hmm.
I mean, I'm one of the old-fashioned people that I will not carry my cell phone in the house. I get home, it's put in a charger, and everybody who needs to get me knows, cell phone doesn't work, try my house phone. Because a couple times I've threatened to give my darling bride's phone a bath. When at 2 in the morning you hear the tinkle tinkle of some text message or something.
Right. She doesn't need to be immediately available 24/7, 365 days a year.
Yeah, and I think the issue there becomes when you're dealing internationally, people are sending you things all night, and you want to be responsive. But there has to be a balance that says, okay, I am going to take some time and just downregulate my responses.
Right.
And I think, the tendency is to upregulate and always want to be a little more, proactive. So, as we're looking at the average person, weight, bad things like drinking before you go to bed, too much stimuli
In the bedroom.
in the bedroom. Yeah, that doesn't sound right, but in my age, it's yes. So, things like TVs, just sit and listen. God forbid you read a book and listen around you to see what's going on. Because I know that, friends of mine have said, they growl about the neighbor's air conditioning, especially in late spring, because they've got their windows open.
Right.
And that thing kicks off. And I mean, realistically, that condenser could go 24/7. So eliminating stimuli makes sense. Looking at chemical or other stimuli and eliminating that, as I sit here with my trough of coffee, alkaloids are my friend, that makes sense. What other things would you tell people?
I would say that if you're getting enough sleep during the usual hours, then you do need to talk to a doctor if you're tired during the day. So symptoms of fatigue during the day are lack of memory and concentration. Most people shouldn't be falling asleep at traffic lights while they're driving or during conversations. If those things are happening, then you should talk to your doctor. So your general doctor will probably check you first for medical problems, a general blood test to make sure your sugar's okay, maybe you're not anemic, thyroid disease, some of the vitamin deficiencies like vitamin B12, but folate, vitamin D. Your general doctor will do that, but quick tests that are recommended for general doctors to ask are, right, so we take everybody's weight and blood pressure. If somebody's overweight and has high blood pressure, then we just have to ask about snoring.
I am the perfect weight if I was only 1.5 feet taller. That I've learned. But since I can't grow, I guess I'm going to have to lose weight.
And I say those things because almost every doctor checks you in, into the room and you get the weight and the blood pressure. And then, it's only a matter of questioning after that to find out, are you sleepy during the day or are you snoring? And those people should be probably sent to the sleep lab. We can also see patients before they go to the sleep lab, and we look for obstructive sleep apnea. People with obstructive sleep apnea are at higher risk for strokes, heart attacks, fatal car accidents, and they're generally not having good quality of life. They forget things that their spouse is telling them. They can be more irritable. It's harder to carry on through the day. Pain is worse when you're tired. It's just a miserable way to be if you're just tired all day.
Well, that makes sense. But I mean, it sounds like some basic questions can help out. I mean, when I hear things like vitamins, I mean, as soon as I hit 50, I got you old man, you take baby aspirin. I always love that, 80 milligrams. It's the only medication I know that's doled out on a per human basis.
That's true.
Doesn't matter your size, your height, your weight. Everything else, I look at milligrams per kilogram. No, 80 milligrams of aspirin because you're old. Okay, so every night I take a little baby aspirin because I was told to. In the morning I take an over 50-year-old vitamin pill. So it amazes me when you start talking about people being vitamin deficient. Is that really legit? I mean, take a vitamin pill. They're pretty inexpensive.
Yeah, again, my specialty is the sleep
Yeah.
and the pulmonary, because I just want to make sure that people understand that obstructive sleep apnea, if we find it and we do treat it, you're right, patients don't want to take medicines. Every medicine has side effect. And so obstructive sleep apnea, sometimes people are irritated by the potential therapy for it, but the oral appliances, CPAP machines, which blow air in and keep the air open, and surgery are the main therapies for obstructive sleep apnea. And none of those are medical, pills at all.
All right, it's one time. So it actually, as we come to the end of this, becomes a very simple thing. Like always, if you think there may be an issue, ask your physician. Ask basic questions. Let him or her walk you through, the options you have. And then if it looks like you do have a problem, then seek out a specialist. Because the quality of life can be affected. And let's face it, life at the center of the universe should be fun. And you shouldn't be sleeping through driving or missing your family. Thank you for coming on.
Thank you for having me.
And as always, to the 6 loyal or 7 loyal viewers we have, may God bless, and may tomorrow you be less sleepy than today if you had an issue. Good night, may God bless, and thank you.